This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
Just a little bit about the history of the Mine Institute. We were founded by 6 families, 5 of whom have sons with autism. And that kind of being forged by families has really meant a lot to us, and we keep that in mind in everything that we do. We are an interdisciplinary center committed to understanding, treating, curing, and preventing neurodevelopmental disorders. And we do that through research, clinical programs, and through education broadly defined, so that we train other professionals, but we also work with community members to train them in issues around advocacy, IEPs, and supported employment, as well as other things. First and foremost, we began around autism, and that remains a central focus for us. But we also study Fragile X syndrome, as Robin mentioned, chromosome 22q11.2 deletion syndrome, Tourette syndrome, attention deficit hyperactivity disorder, and most recently Down syndrome. And I think that one of the things that's really important for us is, and this kind of honors the vision of our founding families, is that we are not a building that has separate programs on these particular conditions. We really are collaborative and interdisciplinary. And so as we have added other conditions to study, we add those that have the potential for synergy, so that by studying these other conditions, we can learn about autism and vice versa. And I think that the families really got it right, because I think this is the most collaborative place I've ever had the privilege of being at. And I think our research is better and more informed because of it. And so why add Down syndrome to what we do at the Mine Institute if autism is at our core and we have these other conditions? And there's several reasons. The first is simply the prevalence. 1 in 691 infants in the United States is born with Down syndrome, and so that's about 6,000 babies per year. And so that's a really prevalent condition that we need to know a lot more about. To put it slightly differently, about 400,000 people have Down syndrome in the United States at any one point in time. And there's a lot we don't understand. And so there's a need for more research. In addition, there really are phenotypic similarities or behavioral similarities, physical similarities, and differences with the other neurodevelopmental disorders we study. And I've just listed a few here. Intellectual disability is certainly an important thing that ties together many of the conditions we study. Even autism is associated with a prevalence rate of intellectual disability of anywhere from 25 to 40% or so. And in contrast to autism, which has at its core kind of a social impairment that we can describe perhaps as a lack of interest in social interaction or a lack of comfort with social interaction, we have Down syndrome that has high sociability. So there's an interesting contrast there that I think we can learn about both conditions from that. And at the same time, there's a more recent puzzle around Down syndrome that even though we think of people with Down syndrome as high in sociability, as enjoying social interaction, there is a high comorbidity with autism. And here's just one recent study that found about 6% of young children with Down syndrome also meet diagnostic criteria for autism. And if you expand that to autism spectrum disorders, it's about 18%. And so there is some controversy about these particular numbers, but it does raise an interesting question of how we can have, in some cases, high sociability, in other cases have this lack of interest in social interaction. And so I think that there's a lot of benefit to studying Down syndrome alongside autism and other things that we do for all of the conditions we study. And so I just want to give you kind of a little bit of an overview of a few things that we have ongoing as well as things planned. And some of these are things that we've planned that I haven't even told my colleagues, and they'll be involved in them, so they'll be very surprised by some of these things. But right now we have a large grant that looks at the factors affecting language development during adolescence. And this is a collaboration with the University of Alabama. At the heart of this particular project is trying to understand why some individuals with Down syndrome develop pretty good language language and others not so good language. We really don't understand why that's the case. And so we're looking at things like memory and approaches to learning new information. We also have a project that should start any day now, also funded by the National Institutes of Health, and looking at creating language measures for treatment studies. One of the things that we know for a lot of neurodevelopmental disorders right now, including Down syndrome, there's a lot of excitement because there are treatment options now that we didn't have a few years ago. Some of those involve drugs, some involve behavioral and educational interventions, but unfortunately we haven't had really good ways of measuring some of the potential effects and benefits of these treatments, and so we would like to develop some language measures that do that, and we have the good fortune of being involved with about with 4 other universities that will be looking at developing language measures for treatment trials. Similarly, we're involved with a consortium led by Johns Hopkins University right now to look at cognitive measures for treatment studies, and that also involves several other universities. And so all of these are ongoing projects. We also have planned a project looking at executive function, or the ability to inhibit and kind of plan one's actions, and temperament and the influences of those 2 factors on challenging behavior, things like aggression, self-stimulation, anxiety. We also have planned a project on emotion processing and its impact on language and social functioning. And then we have, and you'll hear a little bit about all of these today in some way, shape, or form, but we also have, and I'm very excited about this, a really exciting parent-mediated language intervention that we've developed for other neurodevelopmental disorders that we hope to extend to Down syndrome in the very near future. And so this is really just kind of the tip of the iceberg in terms of our Down syndrome program. There is a lot of interest here. It extends beyond just the people up at this panel. And so this really, for us, is a very exciting time. And I hope for the community here who will hopefully participate in our research and benefit from our research. Just a few of our findings from our research, and as Robin mentioned, we're really interested in various aspects of language. And one of the things that you'll see, a lot of our research is focused on finding kind of weaknesses or areas of great challenge or impairment for people with Down syndrome, and I want to kind of return to that at the end. And so this is just a study that we did where we looked at, we have a way of kind of quantifying how intelligible a person, and as you know, intelligibility, speech intelligibility is an issue for people with Down syndrome. And what we were able to show in this particular study is that it's more of an issue for adolescents with Down syndrome, so higher is kind of less intelligible, than for people with Fragile X syndrome who have similar cognitive skills, and for younger, typically developing children. So this is an area of great weakness that we need to do better at targeting interventions. This is, we're often interested in syntax, which is just really kind of the rules for combining language to convey meaning. So it's doing those things like putting things in the right order, marking them for plurality and tense and all of those things. And that too is an area of great weakness for individuals with Down syndrome. So here, higher bars mean that you're more skilled in syntax on these measures. And what we found is that depending on how you measure it, people with Down syndrome have more severe challenges in terms of syntax than even people with Fragile X syndrome who have similar intellectual ability, similar IQs. And so again, there are many areas of weakness, but I think the other thing to keep in mind is that there are many positive and many strengths and positives. And I want to point to this. This is not a study from our lab, but from a colleague of mine, Robin Chapman, who really has done the seminal work on language and Down syndrome. And what you'll see is what she did is she looked at children and adolescents and young adults with Down syndrome and followed them longitudinally. And she measured aspects of their syntax. And as you can see, the important thing is, and each of those lines represents an individual. Every one of those lines is increasing. And the reason that's an important finding is for a very long time, we believe that by the age of about 10 or so, you've pretty much stopped learning syntax and the really important elements of your language, which often was implicitly used to justify why we didn't do very much in terms of speech and language therapy in schools, particularly in high school. And what Robin was able to show is that even into the 20s, which is when she ended her study, people with Down syndrome were continuing to develop language. They were continuing to acquire more information about syntax. And so I think that's something we really need to keep in mind, and that the brain is very plastic and the capacity to learn is there. And then lastly, this is one of the things, and Robin mentioned, is we've been also interested in our research is kind of how parents are doing. Because how parents do determines a lot of how families do and how individuals with Down syndrome do. And one of the things that we've seen in many studies when we've looked at a variety of different dimensions of kind of stress and mental health, and here this is just a measure of kind of depressive symptoms, so higher bars mean more symptoms of depression. And this is comparing, in this case, moms of teens with Down syndrome to moms of teens with autism and moms of teens with Fragile X syndrome. And moms of teens with Down syndrome are doing much better. They have fewer depressive symptoms. And when we looked at why that's the case, one of the big reasons was that there are fewer challenging behaviors in teens with Down syndrome than compared to these other conditions. So this is just a snapshot in time. This doesn't mean life is always easy or life is always good, all right? But what it does remind us is that oftentimes parents of kids with Down syndrome might be in a better place in terms of implementing some therapies and doing things that we ask them to do to support their children than in other conditions. And so I think that that's also a real positive.
So I'm going to switch gears a little bit and talk more about navigating social interactions. And here I'm going to present some data I have on the regulatory function of social referencing. Social referencing refers to an interactive social situation in which one person uses another person's interpretation of a situation to guide their behavior in that same situation. And this is particularly observed in unfamiliar situations where we look to those around us and sort of get a sense of how to proceed. This is a very important part of development because this is a big way in which children learn about people and about objects in their environment. And it's very important for us to remember that there are different pieces that go into navigating this situation. So, for example, a child has to coordinate their attention between objects and people in the situation. So things like initiating looks to an adult and being able to tell what the adult is looking at is very important. And in addition, in order to regulate your behavior in this situation, the child has to use the adult's behavior as a source of information. So they sort of have to interpret the communicative significance about what's happening. And so let's consider the following situation, just to get an idea of what this looks like. So a child and her teacher are playing together, and the child encounters something new, a new object. And she's never seen this before. So she looks to her teacher to see she's really scared of this new object. And so in response to that, the child will probably back away from the situation, maybe get closer to her teacher, probably won't approach it because this isn't good. I don't know about this object. She does. We should stay away from it. And so this is what we wanted to look at in young children with Down syndrome, in this case, preschoolers. And so what we did in the lab was we had children play with familiar adults together, and in the corner, there was a robot underneath a blanket that just started to move, and the adult was excited or afraid of it, and we wanted to know what would happen. And if this was difficult for children to navigate, what is difficult about this situation? And so in this project, we looked at social referencing in children with Down syndrome as well as in children with Williams syndrome. So Williams syndrome is a genetic disorder that's also associated with increased sociability, but has been associated with a few more challenges navigating social interactions than do children with Down syndrome. And so from this comparison, we thought we could get a pretty good snapshot of what challenges both groups of children were encountering. And so what we found overall was in the joy condition, the majority of our children demonstrated a response to the object that was consistent with the adult's response. The adult was excited about the object, the children were excited about the object. Now, in the fear condition, very few children in either group demonstrated a response that was consistent with the adult. And so it looks like something's going on. Interestingly, we've observed important between group differences in both of these situations. So in the joy condition, we saw that the children with Down syndrome were shifting their attention more between the object and the adult, and they were acknowledging the reaction of the adult more than were children with Williams syndrome. In the fear condition, we still saw that children with Down syndrome were shifting their attention more between the object and the adult. We also observed that they were more likely to approach the object. So, what happened? Well, it's really hard to tell because we're talking about a very active situation. There's a lot of things going on. Children are going after robots or not, and it's really hard to tell where a problem encountered. And so what we did is we conducted a couple of follow-up studies to look at the pieces that are important to this process. Initiating eye contact, following another person's gaze to see what they're looking at, and utilizing the communicative significance of joy and fear expressions. And so, from these follow-up studies, we were able to see that children with Down syndrome demonstrated a relative strength in initiating looks to the adult and in gaze following. And that makes sense. We saw in the live task where kids are running around on the floor that they were shifting their attention a lot more than were the children with Williams syndrome. We see that again when we isolate these abilities, that they're doing a relatively good job of coordinating their attention and following someone else's attention. When we isolated the emotional responsivity piece, in particular the fear responsivity, that's where we saw more of a problem. And so this is really important in that what we see is that they may be able to do a couple of these pieces, but not everything is going smoothly. And that can affect how the whole situation proceeds. And so overall, it's important for us to remember that the ability to interpret someone's actions involves a very complex integration of a lot of different things. And so what we were able to see is although children with Down syndrome demonstrated areas of strength, there are also areas of challenge, and these behaviors interact. So just because we see them looking at everything, because we see them responding, it doesn't mean everything is being interpreted the way that we want it to. And so having this sort of multidimensional approach to interactive situations really helps us identify what problem, and in many groups of kids, different problems are being encountered to help us understand how to help our kids reach their max potential in navigating situations. What information do we need to go in and look at and help them with more specifically?
So now I'm going to tell you about a related social skill. It's called emotion knowledge. And this is from a recent research project that I did on emotion knowledge and Down syndrome. So emotion knowledge is this broad term that's used to describe several skills that are related to the ability to understand emotions. So this can be anything from differentiating among one's own feelings to being able to label emotions, learn common causes of emotions, or recognize them in other people. And we use these skills from a very early age to help us succeed in social interactions. So I have an example here, and you can imagine here there are two children playing, and as you can see, there's one child who's reaching out to take the toy from the other child. So now let's imagine that the other child responds negatively to this. It would be important for the first child to be able to pick up on this and use that information to decide how to proceed in the situation. If the first child were oblivious to how he makes the other child feel, then he could act in a way that could escalate the situation and cause it to be more stressful. And while this is a simple example using younger children, the same concept can apply to older children or even adults in a variety of settings. Anything from interacting with peers, making friends, interacting with teachers in a classroom setting, to the home setting, interacting with siblings and parent-child relationships, and even for adults in the workplace, interacting with coworkers. So I recently completed my dissertation research project, and for this project, I decided to look at some of these skills in older children with Down syndrome. And specifically, I wanted to look at their ability to recognize other people's emotions. So there has been some recent research that suggests that children with Down syndrome may have some difficulty with understanding other people's emotions. And if you look at these studies have found that the children with Down syndrome had trouble understanding emotions from still photographs of other people's facial expressions. And so for my study, I wanted to know how well they can understand emotions from dynamic expressions, more like what they would encounter in everyday situations. Also, although the facial expression is often a very strong cue as to how someone else is feeling, it's not the only cue. Often we have their body language or even the broader context in which the emotion is being experienced to consider. So in this illustration, you can see a child covering his eyes, but you really can't see much else in this picture. It would be hard to determine exactly why he's covering his eyes. But as soon as I show you the broader context, it's much easier to determine that the child is covering his eyes probably because he's playing a game of hide and seek, not necessarily because he's upset or sad about anything. So this is a great example of how the social context can help us in deciphering how someone else is feeling in that situation. So for my study, I also wanted to find out how well children with Down syndrome can interpret other people's emotions from different types of cues. And to do this, I created videos of a child actor who we named Charlie, and he expressed basic emotions of joy, sadness, and fear. And in some of the videos, only Charlie's face was visible. These were the face-only videos. And then other videos, the broader context in which the emotion was being experienced was shown. But his face was blurred, so you could not see his facial expression. So in these videos, in one video in particular, Charlie had an ice cream cone and he was eating it, and then he dropped it on the floor. But you couldn't see his facial expression. You could only have what was happening to try to figure out how Charlie was feeling in that video. And then in other videos, the context plus face videos, both the context and Charlie's facial expression were visible. So back to the ice cream example, after the ice cream cone fell on the floor, you would be able to see Charlie making a sad face. So I showed these videos to children with Down syndrome, and after each video, I asked them to indicate how they thought Charlie felt. And they did this by pointing to and verbally labeling an emotion. And then I compared their performance to that of typically developing children of a similar developmental level. And what I found was that the children with Down syndrome were able to judge Charlie's emotions as well as the typically developing children for the face-only videos, for the context-only videos, and for the context plus face videos. And this doesn't mean that they were able to judge Charlie's emotions 100% of the time, but the majority of the time they were accurate, and they were accurate as often as would be expected from their developmental level. So what we can conclude from this is, in general, the children with Down syndrome are able to recognize and label emotions of another child using different types of cues. And they're able to do this as well as typically developing children of a similar developmental level, but who are much younger in age. What we don't know is how the older children with Down syndrome would compare to children their own age. We also don't know how they would do in a live setting where the situation may be more complex than what was in the videos that I showed them. And also, while we know that they were able to pick up on another child's facial expressions and interpret that as an emotion, we still don't know if in a real social setting they are able to then use that information accordingly and regulate their behavior for that situation. So as you can see, there is still a lot we don't know about this topic, and I really hope to, in my future research studies, to consider these questions and to start beginning to answer some of them. And I would like to thank everyone who helped me out throughout the course of this project, and most of all the families, just like you, who participated in these studies and made it all possible.
As Lynn mentioned, I would like to tell you about our parent-implemented or parent-mediated language intervention, early language intervention. Over the past 2 years, we've actually implemented this intervention with a group of moms and children with autism and a group of moms and their children with Fragile X syndrome, and we're very excited about the possibility of implementing this language intervention program with young children with Down syndrome. So we know that the ways in which parents interact with their young children have important implications for children's later language development. So certain characteristics of the way parents talk to their children are especially likely to support children's language learning. So, and parent speech that incorporates those characteristics we term as verbally responsive. So the idea is that these are kinds of language input that all parents use, but that we know are associated with children who have better language outcomes. So the idea is to get parents to do more of this kind of talking to their children so that they can support their children's language development to a greater extent. So the primary goal of early intervention in general is to develop the ability of parents to support their child's development. So not to have a therapist come in and work directly with the child, but have the therapist work with the parent so that the parent can then practice the techniques and the strategies with their own child. So parents can create opportunities to teach their child throughout the day, whereas the therapist may come by the house once or twice a week. And especially with regard to language, but all skills that are important for early development, communication skills that are learned in natural, everyday kinds of activities between parents and their children are more likely to generalize to other situations. And that is, if a child learns something in the context of an activity in the home, he's more likely to use that skill the next time that same activity occurs in his home or when a different activity occurs. Where if a child learns something in a little room in the clinic, he may not use that skill when he gets home with his family. And we also know that, importantly, in this day and age, parent training is cost-effective and results in children having a higher level of exposure to teaching opportunities because the parent has their child with them all day long rather than the child just getting the language intervention once or twice a week for 30 minutes or an hour. So we call our intervention a parent-implemented or a parent-mediated language intervention because the interventionist actually works with the mom, and then the mom works with her own child. So our intervention goals were to teach mothers, or this could be dads as well. In fact, a lot of moms have said, I try to tell the dad what we do in the sessions, but he doesn't want to listen to me, so could you please tell him yourself? So our goal is to teach parents to use certain responsive verbal interaction strategies with their children during everyday routines and interactions. And the three interaction strategies that we're teaching are for the parent to use more talking about their child's focus of attention, for the parent to describe what the child is doing it as they are doing everyday activities so that there's a match between what the child is doing and the language that the child is hearing. For parents to recognize and respond to their children's communication acts. Very often early in development, children's communication acts are very fragile and sometimes parents don't recognize them. And it's really important to respond to children's communication acts for a couple of reasons. One is that it makes the child more likely to initiate communication in the future. And secondly, it provides the child with models of more advanced language that they can learn from. And the third, some children initiate or use communication very infrequently, so our third strategy was to teach parents ways that they could arrange the environment or set up a situation so the child would be more likely to use their communication skills. So, our early language intervention, as I said, it was for young children and their caregivers. And I will mention here, just because I have mothers in here, mothers of children with Fragile X syndrome are, well, Fragile X syndrome is the leading inherited cause of intellectual disability, and whereas Down syndrome is the leading genetic cause of intellectual disability. And mothers of children, mothers of children with Fragile X are themselves carriers of the Fragile X pre or full mutation. And so we're interested in working with mothers of children with Fragile X because we would like to find out what kinds of things we might need to do to address some of the behavioral challenges that, like depression and anxiety, that these moms are particularly likely to experience. But at any rate, wherever I have mothers, you can think parents. So to deliver this intervention, we used a combination of clinic visits and distance video teleconferencing, like Skype is exactly what we used. Because children with autism and Fragile X syndrome often have a lot of challenging behaviors, inattention and head banging and face slapping and other behaviors that are really disruptive to parent-child interaction, we actually had collaboration between a speech-language pathologist and a provider of positive behavior supports, a board-certified behavior analyst. So in this way, we were able to deal with challenging behaviors that might interfere with the parent-child interaction. We used coaching as a way to build parent skills, so to increase parent capacity to intervene with their own child. And we had an emphasis on supporting the child's ability to participate in play-based or caregiving interactions. Many young children with disabilities have limited experiences in which they can learn new skills because they're not able to participate in things like conversations at mealtime or playing with blocks or taking a bath. So when we increase children's ability to participate in daily activities, we provide them with many more learning opportunities. So this is just a slide that shows Ashley Oakes, our speech-language pathologist, and Monica Ma, our board-certified behavior analyst, sitting together and conducting a distance teleconferencing session with a participating family. And we used Mac laptop computers and Skype, and this little icon up at the top is Dropbox. So moms were actually able to videotape interactions when we weren't there and put them in the Dropbox, and then we could give them feedback on the interactions. So at any rate, some of the advantages we think of using distance teleconferencing are that it eliminates travel to the clinic. It enables us to deliver the language intervention in the context of the home, which we think is the big advantage because then parents can learn to work with their children with the everyday materials that they have in their house, not with special toys or special objects that are just at the clinic. And it allows people to have access to services regardless of their geographic location. And actually the study that we just finished with moms and children with Fragile X, we had 12 participating families, and they were actually from 11 different states and Canada. So that was pretty exciting. Okay. So this is just a slide to show you some of the daily routines that we embedded our intervention in. So we asked moms to pick a routine that was problematic for them and to pick a routine that they thought was going really well so that we can show them how to use these language support strategies in the context of both challenging routines and easy routines. So toothbrushing was a big one that we worked on, and making cookies, and getting dressed, and just doing something as simple as being outside playing on the swing. We want to take advantage of all of these different activities as opportunities for language learning. So I'm just going to show a little graph. So you can see on the first part of the graph shows the parent's behavior prior to the intervention, and after the first vertical line, you can see the increases in some of the parent behaviors after the intervention started. And one thing that we're very excited about is that we looked at how the parents were doing during their clinic visits here, as opposed to how they were doing when we did the distance teleconferencing sessions in the home. And what you can see from this graph is that the number of times that parents were using this particular strategy, which was talking about the child's focus of attention, there were no differences between how the parent was doing in the clinic and how they were doing when we provided the session at home by distance, which is a really important finding for us, because now we feel that this shows that we can be just as effective intervening by a distance as we can be when the child is in the clinic with us. So we're very excited about this line of research, and I want to thank all of our Len sometimes thinks I have the entire lab doing the interventions. So and thank you to all the families that allowed us to do this work.
Like Robin said, my name is Heather Green. I am the president of the Down Syndrome Information Alliance, and I also am a mom to an 11-year-old girl with Down syndrome. She was born in 2001, and we had no prenatal indication that she had Down syndrome. And the reason why I share some of this information with you is because my personal story is so intertwined with the Down Syndrome Information Alliance and some of our goals, because as we spent those first years learning about Down syndrome and meeting other families, so much of what we were told was also being told to other parents, and so much of what we were being told was inaccurate information. Even tonight, I'm so excited to sit here and hear a doctor say that children with Down syndrome don't stop learning. Yay! I remember sitting at my 6-week follow-up appointment with our geneticist thinking, I think I feel pretty good about this. She'll just learn slower and at her own rate, but we'll be fine. And he said, oh no, she'll stop learning at some point. So yay for that great information tonight. So like I said, I spent many of the first years learning about Down syndrome, meeting other parents, and eventually that grew into support group meetings in my house, which then in turn turned into us starting the Down Syndrome Information Alliance. Gabby is now 11, and she has 5 other siblings. She's in the 5th grade, and she's very excited to be starting middle school next year. She loves word searches, and she loves playing Monopoly and Battleship, and she loves to jump rope. So that's a little bit about Gabby. Some of the things that the Down Syndrome Information Alliance focuses on is we have a Down syndrome comforter package that we call it, and we hand it out to all of our newly diagnosed families, and it has a new parent guide in it, a couple different books, some DVDs, and information from the national organizations. And this is based on the idea that we wanted our families to have really current, up-to-date information about Down syndrome, because so much of what they were being told was the opposite, was really outdated information. So we wanted to be that place of support that gave them updated and positive information about Down syndrome. Within the past 2 years, we've trained over 30 parent mentors to be that point of contact. So we match them up with the newly diagnosed families, and they're there to answer questions, provide support, and just really be there for that newly diagnosed family. We also provide tons of social activities for all of our family members. For our individuals with Down syndrome, we do dance lessons. We provide opportunities for families to get together, whether it's at the park or Sunsplash and barbecues and breakfast with Santas, so that families are getting a chance to come together, meet each other, and really develop some relationships. Down Syndrome Information Alliance also brings in expert speakers in areas of speech, family relationships, healthcare, to talk to our families. Another thing that we do is have sibling workshops so that we provide our families, the siblings of children with Down syndrome, an opportunity to get together, learn from each other, share their experience, ask questions, just a really safe place to talk about having a sibling with Down syndrome. And then what I'm most excited about going forward this coming year is working on our medical outreach program. And based on some really great research from Dr. Brian Scottco in Boston, working with healthcare professionals on how to give a diagnosis of Down syndrome. So we'll be meeting with OBGYNs and geneticists and doctors all throughout Sacramento and helping them, give them information about how to give an accurate and positive Down syndrome diagnosis. So we're very excited to have this partnership with the Mind Institute, and we're very excited about, the future for all of our families that have family members with Down syndrome.
When I was told to do this, I was very excited. And my pictures appeared. This is me, especially in the pics. My 30th birthday party, and my friends. This is a person, he's got my family here. So that's pretty cool. When my parents, when I was born, parents didn't know I'd be having Down syndrome. They could, and kind of surprised. And
Robert, maybe you could talk a little bit about what you're doing these days in terms of the activities and work that you're doing.
Oh yeah, when I do things at the extra leisure, we go on dances and movies, among other things. So that's pretty cool.
What's your job?
My job? I work for Adam Lyons. I clean the RT label stations. It's a pretty good job, and my hours are good. I get paid very well.
I first met Robert at a Down Syndrome Information Alliance meeting, and
Oh yeah, when I first met this doctor last year, we were what's one called Alfrenados. It was like way upstairs. I was with my couple of friends and their mothers, and they're here tonight.
so maybe you could talk a little bit about your friends, because you're really well connected with a lot of folks that you know. Maybe talk.
Yes, I am.
You have several friends here, right?
Yes, I do.
Maybe you can introduce them, and they would mind standing up and just giving a wave.
Jeremy McCarthy. And Chris Faith. And of course, Amy Lewis. He's on my podium leg with me.
About people with Down syndrome, when they have the extra chromosome, what are the benefits?
What are the benefits? I think that's a very good question. I think that one of the things from a medical perspective, we know, and my colleagues probably know this better than I do, that there are certain forms of cancer and tumors that people with Down syndrome don't get. And so that has a protective factor. I think the other thing that's really important to remember, we try to remember this whether we're talking about people with Down syndrome or people with autism or people with Fragile X syndrome, is that we try to remember not to focus too much on the challenges, but to focus on the real strengths that everyone has. And one of the nice things that I think about that helps make the Mind Institute special is if you walk through our buildings in our hallway here, we have a lot of artwork. It's all done by people that have special needs of one sort or another. And I think it's really cool for a couple reasons. One is it's great art and it makes the place look better and more lively. But the other thing, it's a reminder that everyone can do things And we all have challenges and we all have strengths. I can't paint at all. I can't draw at all. I could never do what these people have. And there's one painting, which is my favorite, which is kind of right across here, right, Terry? And it's painted by a young man from France when he was 14. And he has autism, and he has other problems, kind of bone problems and muscle problems, so he can't hold like a fork, he can't hold a toothbrush, a pencil, or a paintbrush, but he wanted to paint. And so he figured out a way to paint with the side of his hand. He puts the paint on the side of his hand, and it's beautiful artwork. And so I think, for us as professionals that deal with people, I think it's really important for us to recognize that everyone has value, everyone has worth, everyone has strengths, everyone has weaknesses. And the other thing that's important for us to remember, particularly when we're giving a diagnosis or things like that, there is so much we don't know. And we're not very good at saying when we see somebody as a baby or as a 2-year-old, what they're going to be like as a grown-up. We don't really know that much yet. And so I think it's also important for us as professionals to be a little bit more humble about what we know and what we don't know. So does that help answer the question? It's a great question. Thank you for asking it.
Hey, Robert. I know a lot of folks who are really interested in having employment, getting that job, especially that job that pays real wages. I heard you say that, which is really important. I was just wondering, was there one thing that you learned when you got your job working for an alliance that you would share with other people, because it might be a good idea for them to learn? Was there one thing you learned or one thing you did to get that job?
Sure.
What was it? Don't leave me hanging, man.
Wait, what was what?
What was something that you did or that you learned while you were getting that job to work on the light rail stations that you think maybe
Well,
could
I
help somebody
learned
else?
in order to follow the rules.
Follow through with goals?
Yes.
That's a good one. That's a great answer. Thank you.
Be respectful to others.
Hi, I have a 5-week-old son who has Down syndrome, and my question is really for Andrea. You said something about the language intervention. How early can you start that? I mean, they make little sounds and stuff now. He's 5 weeks, but they make little sounds and stuff now. But how early can we start that? And really for the whole panel, is there anything at this stage that I can be doing to be more proactive for early prevention for him?
Yeah. So I'll go first and then, so it's never too early to start providing your child with a lot of language input. So the more that you can talk about what you're doing and what your child is doing, the better it will be. And it's especially important to talk about things that your child is actively involved in. So if you're feeding him, tell him what you're doing. Or if you're giving him a bath, name all the different body parts. Or if you're getting him dressed, name the pieces of clothing. That's something you can do right now. And I was talking about this with someone earlier. We know that children with Down syndrome can really benefit from some visual support when they're learning language. So baby sign is a really great thing to do with children with Down syndrome. So if you can accompany the words you're saying with some simple signs. So if you say open, or do the sign for shoes, or the signs for different animals. So not to sign without talking, but to accompany your talking with these simple signs will be really important. And if you start now, I'm sorry, is your child It's okay. So then he'll have months and months of exposure and all this really good language input before it's time for him to start talking.
And one of the things that we always talk to the moms who are in our language intervention. So we talk about this as we're teaching them to be the language interventionist, the clinician for their child, because they spend more time with their child, they know their child best. You're the person who the child is really going to learn the most from, and in kind of the natural environments way that Annie talked about. The other thing, the thing to keep in mind about that is none of us are perfect, right? And so even though every interaction might be a learning opportunity, sometimes it's hard to be on all the time. And so you have to recognize that sometimes it's okay not to be perfect. And it's also really important, even though for mom, in our slide where I showed you the moms of kids with Down syndrome seem to do pretty well on some of the mental health measures, there's a lot of variability. And it's really important that parents also take some time for themselves to feel supported. And because one of the things that we do know is that depressed parents actually don't do the things as well in terms of interactions. And so, oftentimes we have moms in particular, because we deal often, these are like super moms that never want to stop. They always want to do something for their children, and we worry that sometimes they have to just kind of, chill, get some support for themselves, have a night away or whatever. And so it's really important to do that as well. So, I think that's, it's about the family, not just about the child.
It's really important. Probably the most important thing is for your interaction with your child to be joyful and happy and fun for both of you. So we're just talking about sort of overlaying the little bit of extra language input on things that you're already having fun doing together. And then one other thing that I think is really important is to read to your child, and to start that early, even if it's a little cardboard book that has 3 pages, just to get that sort of habit started when they're really young.
When you have early interventionists, just to echo what Andy said before, is I think it's really important for the interventionist to collaborate with you on the intervention. You should know what they're doing and why they're doing it. Yes. And it's really, they are experts in one way, you're an expert in another way, and it really should be a partnership. And so I think it's really important for them to value you and to incorporate you into everything they do in the home.
Well, show me what to do so I can do it when you're not here. Right. And that's what they should be doing anyway. So don't be afraid to.
If you're interested in being involved in the research here, what is the process to do that?
Oh, good question. So we have a couple of ways that families can get involved in research. If you go to our website, we list particular studies, and this is true whether it's for Down syndrome or autism, other conditions, particular studies that are recruiting right at that point in time. And so you can contact, there'll be contact information there. What you might find, though, is if you look at our studies right now, for example, of the studies for Down syndrome, that they tend to be focused on, right now, I think this is true, older children and adolescents. And so we don't have particular studies for, let's say, 2-year-olds or babies. However, another way to begin to get connected to us and to get information, and also to be kind of the first to hear about research when it's relevant, is that we have ways of registering online into our registry or our database, so that when something appropriate becomes available, we can send you an email or contact you in other ways about those sorts of studies. And it really helps us when families kind of enroll in our registries, because if we are ready to write a grant to the NIH to do research with babies, it would be nice to say, we already have 30 babies that have signed up, well, their moms have signed us up, into the registry, and so that we can kind of demonstrate the plausibility of recruiting those families. And so and what we also try and do is we do try and communicate with families, and I think this is true, that if you sign up into the registry, there's an option for us to send you information and things like that, and it's a way for us to give back to you as well.
And we also have a little sign-up sheet right outside on the table today, so we'd love for you to sign it, and then we'll get in touch with you.
And I have a question for the gentleman here. You mentioned, if I remember the figure, it was 6% you found that tended to be in the unsociable stage, am I remembering
right,
that
it was,
correctly?
They had, in that one particular study, they looked at, I think it was 3 to 11-year-old children, and they basically did a screening, and they had found, at least on the screening, that about 6% of the children with Down syndrome met the behavioral, so autism is a behavioral diagnosis, so they met the criteria for autism.
I was just curious, we have a 25-year-old, and she was diagnosed, of course, with Down syndrome, but also pretty early on diagnosed with something called selective mutism, which for the rest of the people in the room, social phobia would be a good lay term for that. And pretty much everybody that has, you know, the doctors that have seen her have just always said they've just never seen that paired up that way before. And I didn't know if selective mutism fell into that little group that you were talking about.
It wouldn't necessarily, but one of the things that I think you really raise a really important point that I think professionals have not been particularly good about all the time, and that's recognizing that we can have what we call comorbid conditions. And so selective mutism occurs with Fragile X syndrome quite often, for example. And so it's not unusual to have a variety of conditions that kind of co-occur. And the reason I think that that's important is for a very long time when parents would take young adults with Down syndrome to let's say a child psychiatrist or a psychiatrist and say, my son or daughter seems depressed, they seem really sad, they're not eating. We really didn't take it very seriously. We would assume it's part of Down syndrome. And the truth is that just like everyone else, there can be these mental health conditions that co-occur with other conditions. Sometimes it's harder to diagnose in Down syndrome because many individuals with Down syndrome aren't quite as good at verbalizing and those sorts of things. But I think, so it's not unusual to have a variety of conditions that are associated with Down syndrome or with other conditions. I don't know that we know the kind of the prevalence of selective mutism in Down syndrome. I certainly haven't seen many cases of it, as we've worked with families over the years. We certainly have seen some individuals with Down syndrome that are largely nonverbal, but that's because they haven't acquired the language, not because they're because of anxiety and related sorts of things, not using the language. But I think that really raises an important point that many of these things can co-occur or be comorbid.
Hi, just a quick question. What percentage of the disability community is made up of Down syndrome versus autism or?
I don't know exactly the percentages, but I mean, in terms of kind of some of the prevalence numbers, if you just look at kind of the prevalence estimates, the current prevalence estimates are 1 in 691 babies are born with Down syndrome. And autism, it's about 1 in 88 is the most recent prevalence estimate. So certainly autism is more prevalent, but I think that, there are autism is also a very multifaceted condition that probably has multiple causes as well. And again, it is a behavioral diagnosis, so it is not unusual for other conditions. So Fragile X syndrome, 25 to 40%, or even 50%, depending on the particular studies, of those individuals who have a well-defined genetic condition also meet criteria for autism. So we can kind of do those prevalence numbers, and so it is certainly frequent and deserving of public health attention.
Great, thank you. Just one quick follow-up question.
Sure.
Is there a lot of research in the field of why it happens and the actual mechanism of, is it environmental?
For Down syndrome or for autism?
For all
I think
and just one last comment.
Sure.
Thank you for the Mind Institute for focusing on Down syndrome as well.
It's our pleasure. I think that there has been research on mechanisms and risk factors. So one of the most significant risk factors is maternal age. So the risk goes up as women get older. What we don't understand fully is even the mechanism, right? And risk factors are not causal in that sense. And so I think there's a lot that we still don't know. There's been a lot of talk about whether their environmental exposures kind of build over time, and that really accounts for the age effect and so on. Yeah.
Hi, I was just wondering, you talked about treatment studies, and that would be drugs or behavior. If you could just explain a little bit more what...
Sure. I'm a little bit out of my element as a psychologist, not as a physician, but there are right now, I think, there's at least one active clinical trial that's being conducted on a drug for Down syndrome that is specific to cognition in Down syndrome. One of the things that people have looked a lot at and Down syndrome is kind of, can we identify the particular aspects of cognition that are most affected, and can we map those onto particular areas of the brain? And one of the areas that seems to be highly affected is the hippocampus, which is involved in memory. And so a lot of people have focused on understanding more about memory in individuals with Down syndrome. And there is a drug that's in kind of a safety trial now that is targeting some of what people think might be part of the problem with neurons that inhibit responses in the hippocampus, and that this drug may alleviate some of that over-inhibition and may improve memory. It's only, my understanding is only at a kind of a safety trial, but they're also measuring a little bit of memory. We had a colleague, Roger Rees from Johns Hopkins, who is a neurobiologist and works with mouse models, and he came and gave a talk, and they have actually looked at drugs in mouse models of Down syndrome and found really pretty impressive effects. And one of the things that is really, it's a long way to go from a mouse to a person, but they have found improvement in the mice in their learning on some of these drugs. In addition, they have found improvements in when they've done this with older juvenile and young adult mice. And so one of the exciting things about that is maybe we don't always have to intervene right from birth. Maybe the brain is more plastic than we thought. So I think for us as scientists and clinicians, this is a very exciting time because of the drug therapies. I also think we also have to be really cautious about what they can do and how long it's going to take. And my own feeling is, at least for this generation of drugs that we're looking at, that their improvements are probably going to really need to be combined with really good educational services and speech and language therapies. And so it's really all of these things together. I think we are a long way from a drug that will cure the things that we're interested in, because they're so complicated and the brain is so complicated.
5 years ago, when my wife was pregnant with our son who was diagnosed with Down syndrome, we were immediately offered to terminate the pregnancy. Is any of this information that's being gathered going to help for new parents and people, to give them the proper information so that they don't make such a rash decision during their pregnancy?
Well, I think that I'm going to let Heather address that, because I think that that's a part of what you really want to do through the Down Syndrome Information Alliance, is to share information so that parents can make objective decisions, whatever their particular beliefs are, right?
Exactly. So that's one of our focuses for this coming year, is to meet with the medical community. And like I said, based on research, especially from Dr. Brian Scottco out of the Children's Hospital in Boston, he's done fantastic research, interviewing hundreds of moms and dads who've received a diagnosis of Down syndrome, what the doctor said, what they didn't like about it, what would they have wanted the doctor to say instead, and really compiled some great research articles and papers. So our goal is to go forward with that information and meet with the different medical communities, whether it be OBGYNs or geneticists or whoever's giving that diagnosis of Down syndrome, whether it's prenatally or after birth, and try and encourage them to change the way that they're giving these diagnoses, so that parents do have, that accurate information, not necessarily to change anyone's mind, but just so that parents are making informed decisions based on accurate information about Down syndrome. So that is our focus of this year.
This drug therapy that you were talking about, I'm interested in knowing the name of the drug and if there's a way we can follow that research. Is there anything online about that?
I think the answer is I don't remember the name of the drug. The one that they've used in mice, I wrote this down, right? So, because usually what they do with these drugs when they get into clinical trials with people, they give them numbers like STX209. But the one drug that has really been looked at in mouse models is pentylenetetrazole, which I can, if you want to come up afterward, you can write this down. But any clinical trials that are done with people are generally registered at clinicaltrials.gov. And so if you go to clinicaltrials.gov, it's a website run through the government, they will list clinical trials, and you'll be able to see active clinical trials, where they're recruiting, what their requirements are in more details. And so I would suggest that take a look there. And you can search for different sorts of drugs or different sorts of conditions, and it will pull it all up. The folks that are involved in the clinical trial that I know of right now are at Emory University and University of Arizona and Johns Hopkins right now. Now, there may be other clinical trials, and the truth is that we have been contacted about a lot by various drug companies right now. I think that there are going to be more drugs that might be variations on each other that we're going to see in clinical trials. We've been contacted a lot because of our language measure that we're using to help evaluate clinical trials. I think there'll be more and more sorts of drug trials that will be happening in the next couple of years. It really is an explosion. If you look at Fragile X syndrome, there are literally dozens of clinical trials right now, and I don't think Down syndrome will be too far behind. I hope that's helpful.
I have a 5-year-old grandson with Down syndrome. My daughter asked me to ask you this question. Hopefully you'll be able to answer. He has PT, OT, speech. He's in a pre-K, learning the alphabet. He's doing great. Yay. But what she wants to know is what comes next. What type of intervention should be implemented for increasing his cognitive development? So what's the next step?
So, and he's 5?
He's 5.
And so he's ready to get into school, right?
He's in like a pre-K right now. So yes, next, he just turned 5 in September, so next year he'll start kindergarten.
So I can give you my take on this,
Yeah.
right? And you can take this for my biases. I think that your daughter really needs to make sure that she understands his IEP, that she participates in setting goals for him, and that these are goals that are meaningful to the family, and then you have good ways and understandable ways of knowing when you've reached the goals. And so I think that's a really good place to start. I think the other piece of this is, and again, this really reflects my bias, I mean, speech and language is at the heart of what we do in school. And if you're going to have speech and language difficulties, it's really going to be hard to participate fully. And so I think that there needs to be a big emphasis on speech and language therapy. And as Andy suggested, that doesn't always mean being in a therapy room. It might mean incorporating speech and language, making sure everyone is working on speech and language within the context of everything that they do. And I think that, I don't think we do a good enough job of that. The other thing I would say, and this also reflects a bias, is I think that we should make sure that kids with Down syndrome have the opportunity to be exposed to literacy and have an opportunity to learn to read. Many kids with Down syndrome actually do quite well with reading. Some don't, but we're really pretty lousy at predicting who that is for the most part. And so I think we really need to do a better job of that. And so those are kind of my biases, and I'll let the rest of the panel kind of say what they think about that. They're afraid to disagree with me is what it is, just because it's my birthday, so.
With being involved in sports, being helpful?
Of course.
Yes.
Yes.
Other stuff, is it just the regular stuff that we all do?
But any kind of,
There's not a specific, she said, well, we have a little extra money, is there anything we should do?
I think
anything that helps him develop new skills and participate in activities with other kids his age is really important. And in addition to giving him the opportunity to participate and interact, to work on, obviously my bias is speech and language skills, because that really is the foundation for cognitive development and for navigating the world. So sounds like he's on a really good, he's getting a really good start.
And I think the other thing that I would also suggest is that I think it's really important for kids with Down syndrome to be as social as possible in as many different social settings as possible. And I think that that's actually also good for the typical kids. And I think that one of the really important things is that we all, as we talked about with the great question that our friend here gave us at the beginning, that we recognize the value and the strengths and weaknesses that we all have. And so I think it's really important for a full range of social interactions. I do think where it gets really hard to do a lot of those things is when kids get out of school. And I think that there's a lot of effort around getting employment, getting leisure activities, and having more things for these kids to do and have the right to do and be included. But I think that that's absolutely critical.
Two things. I have a 16-year-old with Down syndrome, and the one thing that has really helped my daughter, and I haven't heard it here, is oral motor therapy. And in addition to the speech, in the DSIA, we have a specialist that has come out and have done lectures on oral motor therapy, and I think that is absolutely essential. At least it has been for my daughter. And so incorporating oral motor therapy, talk tools, look up talk tools, Sarah Rosenfeld Johnson. It has definitely helped my daughter. Number two, cognitive enhancement drugs, they have been around for a while. Targeted nutritional intervention has been around for a while. But like you said, doctor, no matter what medication you use, no matter what vitamins and minerals and amino acids you use, it also takes therapy, it takes work, it takes the parents to be involved, the school to be involved, and so forth. And so I want to applaud what you said, because people are sometimes maybe want to look for a wonder drug, but it takes the community to raise a child.
Well, I think the other thing with that too, and again, I think that some of these drugs offer have really amazing potential. But even if we had a drug that normalized brain function, whatever that means, so that the brain would learn from that moment forth in normal ways. If we're going to give that to a 12-year-old or a 14-year-old that has special needs, they've had missed opportunities for a very long time. They've had a different environment for learning, and probably one that's not as challenging in some respects as a normal. So, even under the best, most effective drugs, the environment is important. Parents are important. Big news, right? Parents are important, schools are important, and that's important for everybody. And so I think it's important for us not to lose sight of the fact that there will never be a drug that fixes all of us and makes us all of what we want to be. So it's going to require work, and it requires supports and all of those things in place. And I think it's really important. And that, again, the work on drugs is really exciting and really promising, but it's only part of the answer.
So my question is, I understand that maternal age makes a difference. Traditionally it's made a difference in the numbers of children with Downs. But are you seeing an increase in younger moms?
I'm sorry, I didn't hear the last part of your question.
Are you seeing an increase in younger women with Down syndrome?
With children with Down syndrome?
Children with Down syndrome, yeah.
So if you look at, and Robin, you can help me if I have this right, even though we talk about increased risk as women get older, the risk of having a baby if you're pregnant that has Down syndrome goes up. More babies with Down syndrome are born to younger mothers, because younger mothers have more babies in general, just a proportional difference. And so we have to keep in mind whether we're talking about proportional risk or just frequency. Is that an accurate depiction?
So is the proportional risk going up? Because
over time.
Over time, yeah.
I don't think so. Right. Right. And I think the other thing to keep in mind is that the prevalence of Down syndrome, one of the things, and this relates to your question around abortion, which obviously is an ethical issue and goes beyond what we can talk about. There are tests that will tell you whether the fetus you're carrying has Down syndrome or not. But the prevalence of Down syndrome has not dramatically changed over our lifetimes. In fact, it's a little bit higher prevalence than it was 10 years ago, at least from the CDC reports. And so, I think that there may be a number of reasons for that, but it certainly suggests that people with Down syndrome continue to be an important part of our society. And that's not changing, and I think we have to figure out how our society is more supportive and welcoming of them, just like we have to do that for people that have autism or Fragile X or anything else.
My question is, you showed that graph that showed the plasticity of the brain in learning in the study that was there. Is there a site or a reference that we can go to get information such as that? Because that would be powerful in IEP when they're looking at reducing speech services and those types of therapies, and to be able to say, no, this is not okay, and have that.
Right, so you can go to our website. We have a lot of our papers on the website. For that particular study, if you email me, and I'll give you my card after if you want, I'll send you a copy of that study. It's a little bit older, but I think it's really, for me, it's an absolutely important study. The other thing, which is now relatively new, is that so much of the research on Down syndrome and other conditions that we do in this country is funded by the National Institutes of Health. They, a few years ago, began to mandate that, given that you are all paying for our research, that we are better at sharing information. And so you can go to what's called PubMed, and you can get articles. They tend to be at least published 12 months before you can get them. But for any research funded by the NIH, you can go to PubMed, you can find a research article you want, and if it's more than 12 months old, over the last 10 or so years, you can get a copy of that article. So you can. There's a lot of things now that's available that we used to be really kind of, hoarding. So.
I have another question, and
Sure.
this time about language. How common is apraxia with Down syndrome? So my son is 2.5, and he has some signs, can't be tested yet. So is that maybe the reason why there's some adults who don't have much language? And I was wondering if you could talk about differences in speech therapy or whatever.
I'm
Thanks.
looking for Ashley. Is she here? Is Ashley out there? No. So, what is it?
I don't know the prevalence of apraxia and Down syndrome, and so this is yours to answer
Okay.
then.
All right. I'm looking around madly for someone else to answer this question. So there's a little bit of controversy about whether apraxia of speech really exists as a diagnostic category. So I'm sort of on the it doesn't exist side of things. But with that being said, we think that the speech problems that children with Down syndrome have are related more to things like hearing loss and working memory and low muscle tone in the speech, the mouth and tongue, than they are to something like apraxia. I don't know what else to say about that. Is he?
He has great receptive language in German and English.
Uh-huh.
He has like 100 signs.
Uh-huh.
He has problems making sounds.
Right.
Yeah.
I mean, it could be, I think the issue is there could be a motor planning problem that's
Yes.
part of it.
Yeah.
But I think the other thing that is true, and how old is he?
He's 2.5.
So, one of the things
Very young.
that's very young, and so part of the issue is, we know that for all kids, whether they're typically developing or they have particular conditions, that their reception is a lot better than their expression. It tends to be more exaggerated on average in kids with Down syndrome. So I think that we want to be a little bit cautious about that, just to know whether it really is motor-based. And it may be a contributing factor, but we also know hearing loss is such a big issue in these kids. They have so many ear infections, but it may be other things. But the other thing is that I think is really important is that he has lots of signs. And there was a controversy years ago, and I think that's died away, but just to kind of beat a dead horse on this, is that there was a lot of concern about if I teach my child with Down syndrome signs, am I interfering with them learning spoken language, because we would all like spoken language. And the answer is there is no evidence that interferes. And in fact, the evidence is really contrary, that it actually, in many cases, facilitates the later acquisition of spoken language. And I think for a big reason is we all learn language not to learn language. We learn language to communicate. And so it's really about communication and interaction, which is why I think our parent-mediated intervention is so successful. It's about making interactions positive and great learning opportunities for kids.
And going back to your earlier question, that's why the input matters, even at 5 weeks, at 6 weeks, at 10 weeks. The input that goes in matters. So the fact that your child already has a really strong receptive vocabulary, really focus on building his receptive vocabulary and the expressive part. And 2.5 is really young. So even typically developing children at 2 or 2.5 have loads of articulation problems, and there are sounds that they can't make that a speech therapist wouldn't even address till they were 5 or 6 years old, like a V or a TH or an F. So I would really concentrate on if there are sounds he can't make or a word that he can't say, just to repeat that word back to him really with a lot of emphasis and slowly and where he can see you. But not make it like a drill thing, but just in the everyday course of what you're doing, just to give him lots of input around the words he has trouble with.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.
More about. To put it slightly differently, about 400,000 people have Down syndrome in the United States at any one point in time. And there's a lot we don't understand. And so there's a need for more research. In addition, there really are phenotypic similarities or behavioral similarities, physical similarities, and differences with the other neurodevelopmental disorders we study. And I've just listed a few here. Intellectual disability is certainly an important thing that ties together many of the conditions we study. Even autism is associated with a prevalence rate of intellectual disability of anywhere from 25 to 40% or so. And in contrast to autism, which has at its core kind of a social impairment that we can describe perhaps as a lack of interest in social interaction or a lack of comfort with social interaction, we have Down syndrome that has high sociability. So there's an interesting contrast there that I think we can learn about both conditions from that. And at the same time, there's a more recent puzzle around Down syndrome that even though we think of people with Down syndrome as high in sociability, as enjoying social interaction, there is a high comorbidity with autism. And here's just one recent study that found about 6% of young children with Down syndrome also meet diagnostic criteria for autism. And if you expand that to autism spectrum disorders, it's about 18%. And so there is some controversy about these particular numbers, but it does raise an interesting question of how we can have, in some cases, high sociability, in other cases have this lack of interest in social interaction. And so I think that there's a lot of benefit to studying Down syndrome alongside autism and other things that we do for all of the conditions we study. And so I just want to give you kind of a little bit of an overview of a few things that we have ongoing as well as things planned. And some of these are things that we've planned that I haven't even told my colleagues, and they'll be involved in them, so they'll be very surprised by some of these things. But right now we have a large grant that looks at the factors affecting language development during adolescence. And this is a collaboration with the University of Alabama. At the heart of this particular project is trying to understand why some individuals with Down syndrome develop pretty good language and others not so good language. We really don't understand why that's the case. And so we're looking at things like memory and approaches to learning new information. We also have a project that should start any day now, also funded by the National Institutes of Health, and looking at creating language measures for treatment studies. One of the things that we know for a lot of neurodevelopmental disorders right now, including Down syndrome, there's a lot of excitement because there are treatment options now that we didn't have a few years ago. Some of those involve drugs, some involve behavioral and educational interventions, but unfortunately we haven't had really good ways of measuring some of the potential effects and benefits of these treatments, and so we would like to develop some language measures that do that, and we have the good fortune of being involved with about four other universities that will be looking at developing language measures for treatment trials. Similarly, we're involved with a consortium led by Johns Hopkins University right now to look at cognitive measures for treatment studies, and that also involves several other universities. And so all of these are ongoing projects. We also have planned a project looking at executive function, or the ability to inhibit and kind of plan one's actions, and temperament and the influences of those two factors on challenging behavior, things like aggression, self-stimulation, anxiety. We also have planned a project on emotion processing and its impact on language and social functioning. And then we have, and you'll hear a little bit about all of these today in some way, shape, or form, but we also have, and I'm very excited about this, a really exciting parent-mediated language intervention that we've developed for other neurodevelopmental disorders that we hope to extend to Down syndrome in the very near future. And so this is really just kind of the tip of the iceberg in terms of our Down syndrome program. There is a lot of interest here. It extends beyond just the people up at this panel. And so this really, for us, is a very exciting time. And I hope for the community here who will hopefully participate in our research and benefit from our research. Just a few of our findings from our research, and as Robin mentioned, we're really interested in various aspects of language. And one of the things that you'll see, a lot of our research is focused on finding kind of weaknesses or areas of great challenge or impairment for people with Down syndrome. And I want to kind of return to that at the end. And so this is just a study that we did where we looked at, we have a way of kind of quantifying how intelligible a person, and as you know, intelligibility, speech intelligibility is an issue for people with Down syndrome. And what we were able to show in this particular study is that it's more of an issue for adolescents with Down syndrome, so higher is kind of less intelligible, than for people with Fragile X syndrome who have similar cognitive skills, and for younger, typically developing children. So this is an area of great weakness that we need to do better at targeting interventions. This is, we're often interested in syntax, which is just really kind of the rules for combining language to convey meaning. So
This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
Just a little bit about the history of the Mind Institute. We were founded by 6 families, 5 of whom have sons with autism. And that kind of being forged by families has really meant a lot to us, and we keep that in mind in everything that we do. We are an interdisciplinary center committed to understanding, treating, curing, and preventing neurodevelopmental disorders. And we do that through research, clinical programs, and through education broadly defined, so that we train other professionals, but we also work with community members to train them in issues around advocacy, IEPs, and supported employment, as well as other things. First and foremost, we began around autism, and that remains a central focus for us. But we also study Fragile X syndrome, as Robin mentioned, chromosome 22q11.2 deletion syndrome, Tourette syndrome, attention deficit hyperactivity disorder, and most recently Down syndrome. And I think that one of the things that's really important for us is, and this kind of honors the vision of our founding families, is that we are not a building that has separate programs on these particular conditions. We really are collaborative and interdisciplinary. And so as we have added other conditions to study, we add those that have the potential for synergy, so that by studying these other conditions, we can learn about autism and vice versa. And I think that the families really got it right, because I think this is the most collaborative place I've ever had the privilege of being at. And I think our research is better and more informed because of it. And so why add Down syndrome to what we do at the Mind Institute if autism is at our core and we have these other conditions? And there's several reasons. The first is simply the prevalence. 1 in 691 infants in the United States is born with Down syndrome, and so that's about 6,000 babies per year. And so that's a really prevalent condition that we need to know a lot. Times parents of kids with Down syndrome might be in a better place in terms of implementing some therapies and doing things that we ask them to do to support their children than in other conditions. And so I think that that's also a real positive.
So I'm going to switch gears a little bit and talk more about navigating social interactions. And here I'm going to present some data I have on the regulatory function of social referencing. Social referencing refers to an interactive social situation in which one person uses another person's interpretation of a situation to guide their behavior in that same situation. And this is particularly observed in unfamiliar situations where we look to those around us and sort of get a sense of how to proceed. This is a very important part of development because this is a big way in which children learn about people and about objects in their environment. And it's very important for us to remember that there are different pieces that go into navigating this situation. So, for example, a child has to coordinate their attention between objects and people in the situation. So things like initiating looks to an adult and being able to tell what the adult is looking at is very important. And in addition, in order to regulate your behavior in this situation, the child has to use the adult's behavior as a source of information. So they sort of have to interpret the communicative significance about what's happening. And so let's consider the following situation, just to get an idea of what this looks like. So a child and her teacher playing together, and the child encounters something new, a new object. And she's never seen this before. So she looks to her teacher to see she's really scared of this new object. And so in response to that, the child will probably back away from the situation, maybe get closer to her teacher, probably won't approach it because this isn't good. I don't know about this object. She does. We should stay away from it. And so this is what we wanted to look at in young children with Down syndrome, in this case, preschoolers. And so what we did in the lab was we had children play with familiar adults together, and in the corner, there was a robot underneath a blanket that just started to move.
Doing those things like putting things in the right order, marking them for plurality and tense and all of those things. And that too is an area of great weakness for individuals with Down syndrome. So here, higher bars mean that you're more skilled in syntax on these measures. And what we found is that depending on how you measure it, people with Down syndrome have more severe challenges in terms of syntax than even people with Fragile X syndrome who have similar intellectual ability, similar IQs. And so again, there are many areas of weakness, but I think the other thing to keep in mind is that there are many positive and many strengths and positives. And I want to point to this. This is not a study from our lab, but from a colleague of mine, Robin Chapman, who really has done the seminal work on language and Down syndrome. And what you'll see is what she did is she looked at children and adolescents and young adults with Down syndrome and followed them longitudinally. And she measured aspects of their syntax. And as you can see, the important thing is, and each of those lines represents an individual. Every one of those lines is increasing. And the reason that's an important finding is for a very long time, we believed that by the age of about 10 or so, you pretty much stopped learning syntax and the really important elements of your language, which often was implicitly used to justify why we didn't do very much in terms of speech and language therapy in the schools, particularly in high school. And what Robin was able to show is that even into the 20s, which is when she ended her study, people with Down syndrome were continuing to develop language. They were continuing to acquire more information about syntax. And so I think that's something we really need to keep in mind, and that the brain is very plastic and the capacity to learn is there. And then lastly, this is one of the things that Robin mentioned is we've been also interested in our research is kind of how parents are doing. Because how parents do determines a lot of how families do and how individuals with Down syndrome do. And one of the things that we've seen in many studies when we've looked at a variety of different dimensions of kind of stress and mental health, and here this is just a measure of kind of depressive symptoms, so higher bars mean more symptoms of depression. And this is comparing, in this case, moms of teens with Down syndrome to moms of teens with autism and moms of teens with Fragile X syndrome. And moms of teens with Down syndrome are doing much better. They have fewer depressive symptoms. And when we looked at why that's the case, one of the big reasons was that there are fewer challenging behaviors in teens with Down syndrome than compared to these other conditions. So this is just a snapshot in time. This doesn't mean life is always easy or life is always good, all right? But what it does remind us is that often